morning. This is Miss Terry, and we are going to discuss Unit 7. That is chapters 13, 14, 29, 31, and 32. Perhaps the most important chapter in this lecture is going to be chapter 13, Drug Therapy for Diabetes. You will see many diabetic patients while you're training and doing your nursing care, so it will be real important to understand diabetes, the implications of diabetes, the medications used, especially insulin, and teaching that you're going to do with your diabetic patients, etc. I'm going to try to, I think today, lecture off of the PowerPoint versus the chapters. I'll refer back to the chapters, but so if you'll get your PowerPoints out, that might be a little bit easier to understand. Of course, there's two types of diabetes, and we'll talk about that more in depth, but type 1 and type 2. But the pathophysiology, I am going to refer to my textbook. Glucose is the most common simple carbohydrate and the main source of fuel for our body. So we need glucose to give us our energy, and we get that from other simple carbohydrates are the main fuel that we gain our metabolism through. The pancreas is an endocrine gland that makes two hormones, insulin and glucagon. These hormones are important for using the right fuel in the body and maintaining blood glucose levels. So the pancreas is the main organ, and it makes two hormones, insulin and glucagon. The beta cells of the pancreas make insulin, and the alpha cells make the glucagon. And you can see that in figure 13.1. Together, insulin and glucagon ensure that the right amount of glucose is always present in the body. And that then becomes what we talk about as the metabolism, or our energy. And it's the metabolism is the energy used by each cell and the amount of work performed within the body. So you need to remember that the pancreas, and actually it's called the islets of Langerhans. That's the actual spot on the pancreas where insulin and glucagon are made, or where the alpha and beta cells are, but it's called the islets of Langerhans, and that is within the pancreas. Insulin is the hormone produced by the beta cells of the pancreas to prevent the blood glucose levels from becoming too high, as we talked about. Well, we'll go through that here in just a minute. Together, insulin and glucose, as I said, establish how well our metabolism is doing in our body. And glucose is the most common simple carbohydrate and the main source of fuel for the human body. ATP is inside our cells, which is the main chemical energy substance that drives all of the cellular reactions of the body. So ATP. The body makes its own ATP from glucose along with oxygen. So people need an adequate amount of glucose in the body ready to enter the cells and make sufficient amounts of ATP. Euglycemia is the normal fasting blood glucose level, and that should be between 70 and 110. So what we ask our diabetic patients is, when they get up in the morning and they're fasting, they haven't eaten throughout the night, they need to take their blood sugars, and it needs to run between 70 and 110. Now, an occasional number above 110 you're not necessarily diagnosed with diabetes, but if that is consistently high, then you are considered a diabetic. And I used to call it pre-diabetes and that sort of thing, precursor to diabetes, but nowadays, if you are consistently above 110 fasting glucose, you are considered a diabetic. Excuse me. Insulin is the hormone produced, as we talked about, by the beta cells of the pancreas to prevent blood glucose levels from becoming too high. a blood glucose level above 110 is called hyperglycemia. Hyper, as you know, means high. Hypertension, hyperkalemia. So hyper means high. So hyperglycemia is a blood glucose level that is too high. And when they're high, that is the trigger to the beta cells. So when the glucose level in the blood is high, then the beta cells realize that, and they then make insulin to lower those blood sugar levels. And they get that insulin out into the bloodstream, and they want then that sugar to go back into the cells. They want it out of the bloodstream and into the cells. And this isn't in your book, but what happens is that sugar in the bloodstream has kind of like little spikes on it, and as it travels through the bloodstream, that is what causes the injury to blood vessels, to organs, and that sort of thing. So they want that blood sugar in the cells so that it's not causing injury. The most important thing to remember is that insulin lowers blood glucose levels. So insulin lowers that glucose that is in the bloodstream. Insulin is also called the hormone of plenty, because in the healthy person eating well, so if you eat a lot of carbohydrates, proteins, fat, and your fats all rise, then that's when you start having problems with your blood glucose levels. Glycogen is the human starch that serves as the storage form of extra glucose. So when there's more glucose than needing, it converts itself to glycogen and stores, so that when we need it, then the body can release that glycogen back into the cells to give us energy. Insulin helps to control protein and fat metabolism. When the blood sugar when the glucose levels in the blood are too low, it's called hypoglycemia, and that reduces body metabolism, because not enough glucose enters our cells, remember, to make that ATP, which helps us get our energy. And hypoglycemia is very serious and can cause death. Very, very serious. Glucagon, as we talked about in the previous slide, is the hormone released by the alpha cells of the pancreas that prevents the hypoglycemia that by breaking down glycogen, which is the stored into glucose. So glucagon is the opposite of glycogen. So glucagon is the hormone that prevents the low blood sugar by breaking down glycogen into glucose. It is released whenever blood glucose levels get too low. In addition to being a normal hormone, glucagon is also a drug used to treat severe hypoglycemia. So if your patient is having a hypoglycemic attack, then we can give them glucagon, and that helps then raise those blood sugar levels. So remember, glucagon and insulin have opposites effects. Insulin lowers blood sugars, and glucagon helps raise blood sugars. Make sure you understand that pathophysiology. So diabetes mellitus is a common metabolic disease that results from either the loss of the ability to make insulin or the loss of the receptor sensitivity to the presence of insulin. So there's two types. Type 1 is diabetes mellitus 1, which is what used to be called, and still sometimes is, juvenile diabetes. In juvenile diabetes, so juvenile meaning normally that is what is found in the young population, sometimes teenagers. I've years ago took care of a little child that was 3, and she was diagnosed with diabetes. So it can affect the very young children, teenagers, but the young. And what happens is their pancreas just doesn't even produce insulin. So the body switches and uses that fat, your fat, then to make ATP, which is the energy. And then that's what causes all the problems with the young people, because their body is breaking down their fat for energy and causes a lot of health problems. And so usually type 1 is genetic, and patients will have to use insulin for the rest of their lives. So their pancreas does not produce insulin. So their first symptoms usually are polyphagia, polydipsia, and polyuria. You need to learn those 3 terms, but they all mean excessive thirst, excessive drinking of water, and excessive urination. Type 2 is much more common. Usually the older we get, the more susceptible we are to type 2. Your insulin is slightly functioning, so it is producing some insulin receptors, but it's not, we're not real sensitive to those. And so we can encourage our good body functions by either taking in medicines for hyperglycemia or insulin. Sometimes diabetes 2 can be considered genetic. Certainly you have a predisposition if your parents or your grandparents had diabetes, then the physicians will tell you that you are at risk, a greater risk of becoming a diabetic. But also obesity, sedentary life, your diet usually is a big factor in a person getting diabetes 2. Insulin, in diabetic 2, insulin does not bind as tightly to its receptors unless glucose moves from the blood into the cells. So you keep that glucose in the blood rather than the cells, and that then is what why you are hyperglycemic. The problem with diabetes is the long-term effects of, well, there's many problems, but the long-term effects of diabetes affects the heart, the kidney, the brain, the eyes, the legs, feet. You get peripheral neuropathy, which is nerve endings in the feet and the hands, so it's damage to the feet and hands. Excuse me. And therefore, many diabetics get what we call stasis ulcers, so they start getting ulcers on their lower legs or on their feet. You'll hear about amputations of toes and then feet and then lower legs, and just a lot of severe side effects of diabetes. So remember, patients with type 1 produce no insulin, whereas patients with type 2 produce insulin, but the insulin receptors are not real sensitive to it, so do not go in there and attach to it and move that sugar out of the blood. Type 1 must get exogenous insulin to survive and prevent ketoacidosis. And ketoacidosis is ketones, a rise in ketones in the body, and can lead to death. When I was in ICU, it was not infrequent to get patients in ketoacidosis, and they are critical when that happens. So they just get too many ketones in the body, it spills over into the blood, and then they're on a downward spiral. With either type 1 or type 2, blood sugars must be within those normal limits that we talked about, 70 to 110, to avoid those long-term effects of diabetes. The goal of diabetic treatment with insulin is to maintain those blood glucose levels within normal range to avoid the ketoacidosis and prevent those vessel and organ damage. Insulin is a high alert drug. It can kill someone if you give it to the wrong patient, if you give too much of an insulin or too little of an insulin. it has to be double checked by 2 nurses. It is a high alert drug. Insulin moves the glucose into the cells to be utilized. Remember, it takes it from the blood and it puts it into the cells. It helps control diabetes, but it does not cure diabetes. Once you have diabetes, you have diabetes because that pancreas just isn't working correctly. Now, you can control diabetes. You can get those blood sugar levels under control by medication. Even without medication, some diabetics can control theirs by their diet and exercise, change their way of life, and it can be controlled without taking insulin or without even taking oral medicines. If you get a hold of your diet, you get a hold of your activity level, you can, not all patients, but you can control your blood sugar levels. The most common problem with insulin, of course, is hypoglycemia. So if you give the patient the wrong amount of insulin, if you give them too much, you can cause that blood sugar to drop way too low, and that then can lead to death. So there are different kinds of insulin, and those can be found in your textbook under types of insulin. I highly encourage you to look at those. They're called rapid acting insulin, and that's Novolog, Humalog. And as you see, the onset's within about 15 minutes. So then there's a peak time when the best response occurs within 1 to 3 hours, and then it lasts 3 to 5 hours. Now, what does that mean? Okay. So fast acting is usually what patients will take if they're on longer acting and fast acting insulin. They can be on 2 different types. Fast acting they take right before they eat. So you see it affects the body within about 15 minutes. Now, what does that tell you? And we'll talk about it more, but that tells you that if you give somebody a fast-acting insulin, you need to have a meal ready. You can't give them a fast-acting insulin and then dietary, not get the trays on the floor, and you remember, I gave that patient insulin 20 minutes ago, because their blood sugar is going to drop, and if it wasn't that high, then it can drop significantly in 15 minutes. So what you always have to remember is that you need to check to make sure there are snacks on the floor. And I'm sure they still do, but when I nursed on the floor, we had little sack lunches always in the icebox on the medical unit, consisting of either half a sandwich or crackers or fruit, something that will, half a sandwich meaning peanut butter or something like that, cheese, that will rapidly get that blood sugar back up. Orange juice was always on the unit, that sort of thing. So you have to make sure if you give a rapid acting insulin that you have a snack available on the floor, and you're getting on the phone to dietary asking where their meal is. I had a very good friend that was in the hospital just last week, a big hospital in Dallas, and he is a young man and is very versed on his diabetes. The nurse came in to give him his insulin, and he said, I ordered my diet 45 minutes ago and it's still not on the floor, so you can't give me my insulin. So very, very smart of him, because as a matter of fact, when I went back to see him, his tray was even more delayed, and he did the right thing by telling her to hold off on his insulin. So remember, fast acting, the onset is within 15 minutes. Short acting, Humulin regular, that's within 30 minutes to an hour. And then you have intermediate, which is called like NPH. So the short acting is usually called Humulin regular insulin, and then intermediate is usually what we call NPH insulin. And there are different, as you see there in the chart, there's different kinds of intermediate acting insulin. And then long acting is usually Lantus, something like that, and that lasts about 24 hours, and it peaks within about 2 hours. The thing about, I don't mean it peaks, okay, take that away. It lasts, the duration is 24 hours. There is no peak time with long acting, okay, so there's no peak time. And so patients will take long acting, usually in the morning, and then in the afternoon, and then, or in the morning, and then in the evening, okay, so that they're, when they go to bed, they'll take long acting, and that'll get them through the night. Then when they get up in the morning, they will take a long acting that'll get them through the day, okay? But then before meals, not all patients, so it depends on your patient, but then before meals, they'll take that rapid acting to get their blood sugar down. A lot of times then they will check their blood sugar 1 hour after eating, and if their blood sugar is still up, they'll take another dose of short acting. So there's all different ways to administer insulin, but you just need to know that there are these 4 categories. You need to know which ones act rapidly, which ones don't, which ones have a peak time, and you need to know that long acting does not have a peak, and you need to know their duration times. Okay, hope that helps you. Okay, do not use rapid acting insulin, short acting, and insulin glargine or insulin detamere if the liquid in the bottle is cloudy. All other insulins are cloudy, and so there are some that are clear and some that are cloudy, and you need to know which is which. You never shake a vial of insulin. You gently roll it in your hand. You're kind of warming it up so it's not harmful to the tissues. You just sort of gently roll it in your hand. So you need to know which ones are cloudy and which ones are clear. Okay, and then if you will look in your book, they talk about the sites, the common injection sites, and we want our patients to rotate sites that prevents the potential for infection in the skin. There's a guide here for mixing 2 types of insulin. I'm sure that you're going to learn that in med administration, so we're not going to talk about how to mix it. So we want our patients to put it across their abdomen, tops of their legs, and their arms and their back. A physician I just talked to not long ago said just to go across the abdomen. Now, you don't want to go real close to the umbilicus, but otherwise, he said you just march it out Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, across the top of your abdomen, and then start back over Sunday, Monday, Tuesday. And I thought that was a good way to teach a diabetic just how to remember to, because many diabetics are elderly, they're forgetful, they're all kinds of things. And so you have to give them clues on how to remember. Don't just put it in the same site all the time if they're giving their own selves injectable insulin, not taking the oral medications. Okay, insulin injected into the body works in exactly the same way as insulin that is secreted by the pancreas. Hypoglycemia, as we talked about, is what we call insulin shock, and it's always a potential adverse effect of insulin, so you can put somebody into shock. The signs and symptoms of hypoglycemia, so if they're low, are anxiety, clammy skins, headache, hunger, sweating, tremors, and they can get very confused, loss of consciousness. So if you ever, and I have in the workplace, been called to come look at somebody that's not acting right, confusion is very common, and the first thing you start saying is, are you a diabetic? Have you eaten? Have you taken some medicine recently? That sort of thing, because they will definitely get confused. And then they can lose consciousness and can die. Side effects are insulin site injection that we talked about. and changes at the injection site. So that's why you want to rotate. And we talked about the snacks, and we talked about the regimens of giving the insulin, 1 dose, 2 dose, 3 dose, 4 doses. You always only use an insulin syringe. It is different than a tuberculin syringe, any other syringe. There's always an insulin syringe that will be on your unit. Okay, hyperglycemia, we talked about that. That's when the blood sugar is considered greater than 150. There are many diabetics that you will see who have blood sugars in the 200s, very common, 300s, even 400s. And that is very serious. That is uncontrolled diabetes. And we talked about the ketones that will get ketonuria, which are the ketones that spill over into the urine. They will become tachycardic. They definitely get what they call an acetone breath, and you can smell it when they come in, and you know they're not real responsive, and you've done some lab real quick, and you're finding out they have ketones. You can smell, it's a kind of a fruity smell. You can smell it in their breath. Hypoglycemia, when they become low, as we talked about a little bit earlier, they get very cold, clammy, nervous. The first thing you want to do is, like I said, are you diabetic? Go get a glucometer if you're in the hospital, get their blood sugar checked. If it's less than 60, you need to start doing something, trying to get something down on them to get that blood sugar up. You can administer glucagon, as we talked about at the beginning, and that is there is an injectable form of glucagon. I have been in people's houses and seen a call to EMS, and they immediately get an IV started and inject glucagon. You can, I believe, I'd have to double check, but you can put glucagon underneath the tongue. But jelly, anything like that that's got some carbs in it. So you want them to take in some high carbs. Now, diabetics can get hypoglycemic if they exercise too much. So they're always having to watch how they feel. They know the signs and symptoms, most of them do, of low blood sugar. Skipping meals, classic sign of why they become hypoglycemic. So you want to always tell your patients, never, ever, ever skip a meal if you're a diabetic. If your family member is one, you need to always have peanut butter crackers or cheese or something like that, even hard candy with you if you go to the ballpark to watch a game, and for some reason you haven't gotten a meal down, then you need to have something available. Okay. Regular exercise they need to do, and watch their diet. As I told you, it was a high alert drug. So insulin administration, you want to check your orders against your medical record, and double check those orders. Verify what your blood sugar is before you give that insulin. Make sure it's not too low. If they're on a morning regimen and you've just come on work and you see their insulin was 58, their blood sugar was 58, and a lot of times that's taken on the night shift right before you come to work at 7, and you see it's 58, and you're, oh, I better not give this insulin, because if it's less than 60, you don't need to be administering insulin without calling the doctor. Requires 2 nurses' signatures. You date and time any new bottle that you open, because there is an expiration on those bottles. And make sure, as I told you, that there's snacks. And then there are some insulin pens, and the patients can keep those at home in their refrigerator, but Levemir, it says here, is not. That's not a test question. Other forms of insulin, people can have what we call an insulin pump. I have a very good friend who's had a pump for years, and so it is administered through their abdomen, and the pump is external, and it monitors their blood sugar, and they can give themselves without having to inject. And then there's other anti-diabetic drugs that are non-insulin. They can be oral or injectable, and they may use one or two of these drugs and insulin, so it gets very complicated for the diabetic patient and family. Give with food, make sure there's a snack. So there's 7 kinds of non-insulin anti-diabetic drugs. Insulin stimulators, insulin sensitizers, alpha glucosidase inhibitors, incretin mimetics, amylin analogs, DPP4, and sodium glucose contrasport inhibitors. I hope on your blueprint I have listed any med that I need you to know. You need to kind of recognize these categories, but I will not ask you all of these, certainly. And I'm not going to go through all of these. I think you can read this about each one, but and what they do. So each stimulate beta cells to release insulin slowly, or some release insulin in a burst, and make the receptors, insulin receptors more susceptible to insulin. That's Avandia, and that is a thiazolinidones. And you need to weigh the patient daily because these can cause congestive heart failure. Be sure you know that. Biunides, which is glucophage, or metformin. You hear a lot about metformin. That's a new one on the market, very expensive. It causes a lot of stomach upset, and it can cause lactic acidosis. Also metformin, then because of all the stomach upset, patients don't want to eat, so they'll lose a lot of weight with that one. And DTP is Januvia. You see that on TV a lot. Okay. Chapter 14. We're going to move on rapidly here. I talked a lot about that. Chapter 14 is drug therapy for thyroid and adrenal gland problems. The adrenal glands sit right on top of the kidneys, and the thyroid system, you know, the thyroid is here. Okay, an endocrine gland secretes one or more hormones into the blood, which then targets a tissue. The target tissue is a tissue or organ that is affected or controlled by a hormone. So the endocrine gland secretes the hormones into a target tissue. The thyroid gland is located in the front of the neck, just below the Adam's apple. It produces 2 thyroid hormones, T4 and T3. These 2 hormones are formed from the amino acid tyrosine and the mineral iodine. Okay? When T3 and T4 leave the thyroid and enter the cells, they bind to receptors inside the cell and activate the genes for metabolism. So these are responsible for metabolism, or your energy. Thyroid hormones increase the rate of metabolism, so they speed up energy use. They assist in brain development, brain function, ability to think, maintain heart and skeletal function, and ensure production of other hormones, maintain your respiratory function, and cell uptake of oxygen. So you see how important that T3 and T4 are, that these 2 hormones, how important they are into managing our body system. Hypothyroidism is low thyroid function, causing low levels of thyroid hormones. So you think about it, if these hormones provide energy, metabolism, what happens if they're low? So you're going to get tired, your heart is going to get weak, you're going to have constipation, your system is just slowing down. Slow reflexes, cold skin, the blood is not pushing through your body, dry skin, hair thin, all those sort of things. So remember, iodine is what is needed to make T3 and T4. Once you start taking a thyroid replacement, you have to take it for life. Thyroid hormone replacement therapy are called thyroid hormone agonists. And those are levothyroid or cytomel. They have few side effects. The adverse effects are, now you think about it, if it's slow and you're taking something to speed it up, then what's going to happen? You could get tachycardia, leading to heart attack and heart failure. So the doses for these are very, very important. You get increased activity. Everything increases. So increased activity of the nervous system, so you can have seizures. And you need to be very cautious with patients on Coumadin. What causes hyperthyroidism? Graves' disease, which is an autoimmune disease, a goiter. So patients get goiters, and you can see that in your book. Toxic adenoma, and then exogenous. In other words, if you're taking medication, you can get too much. Signs and symptoms of hyperthyroidism. Is, I can't read my chart. Difficulty sleeping, being warm, fine tremors of the hand. So really what you think about is everything is sped up. So you're gonna get tremors, that sort of thing. You also get a facial appearance of Graves' disease, and that's bulging eyes. And you can see a picture of that. And we also call it thyroid storm. If patients' thyroid gets too high, they can go into a crisis called a thyroid storm, and they can die. Thyrotoxicosis is another name for high thyroid. Thyroid suppressing drugs I have listed in your slide. PTU and Northex, and they can cause bone marrow suppression. They're toxic to the liver, and also watch patients on Coumadin. It's a permanent health problem, and it's usually treated by removing the thyroid gland. So 1, they have to take medicine for the rest of their life. 2, they may have to have their thyroid gland removed. Your adrenal glands, as I mentioned earlier, sit on top of your kidneys, and they produce cortisol or glucocorticoids, mineralocorticoids or aldosterone, which we've already read about, and sex hormones, testosterone. That's the adrenal cortex. The adrenal medulla releases epinephrine and norepinephrine. So you can see how important the adrenal gland is with all of these steroids, the testosterone, and the epinephrine, fight or flight hormone in the body. If your adrenal gland is low functioning, so the cortisol, which is our ability to react to stress, carbohydrate, protein, and fat metabolism, our emotional stability, our immune system, water balance, all of that is what cortisol regulates. Aldosterone regulates our sodium and water, and the patient will die if they don't get these back into their body. So we give corticosteroids or prednisone and Florinef to restore the sodium and water. And then, if you're messing with the water and sodium balance, you can have congestive heart failure. Adrenal gland hyperfunction, we give either Lysidren or Corlium, or there are others. I just listed a few. And so they get too much cortisol or too much aldosterone. Be sure and read this chapter. I went over it pretty fast. It is a short chapter, but I don't want you to think it is not important, because you will certainly have questions on this chapter. All right, moving right along, we're going to go to chapter 29, which is what I'm trying to get over to. This is becoming a long lecture for you already. Okay, drug therapy for eye problems, chapter 29. The problem we will most at length we'll talk about is glaucoma. And I also want you to know the parts of the eye. I want you to know what meiosis is, mydriasis is, photoreceptors, vitreous humor, aqueous humor. You need to know what intraocular pressure is, and that is what glaucoma causes, and that is the internal pressure in the eye, ball in the eye, and it's caused by an increase in the amount of aqueous humor. The most common type is a chronic condition called primary open-angle glaucoma, and that affects both eyes, and many elderly patients have glaucoma. Not necessarily, you don't have to be old to get it, but many elderly patients you will see have glaucoma, and they have to use eye drops for the rest of their life to keep that pressure on the inside of their eye low. That's the point of that. They want that intraocular pressure low. And it doesn't cure glaucoma, but the drugs do help. Now, I don't know a lot about it, but I have seen patients who have cataracts. The physician has done a surgery in which he said, I'm going to try to cure your glaucoma at the same time, and I have seen it done. I don't know what he did, but the cataracts were taken out and replaced with a new lens. Whatever he did decreased the intraocular pressure. I was in the office when he looked at that patient after the surgery. I think it was the very next day, and he did a little slice in the eye, and this aqueous humor came out, and the patient has never had glaucoma again. That was amazing to me. So there is a surgery that can sometimes help patients who have glaucoma, but in general, they have to take the meds for the rest of their life. And so what does the intraocular pressure do? These are some kind of vision pictures of how their vision is distorted. Then the meds that they take are prostaglandin agonist, alpha adrenergic blockers, cholinergics, beta blockers, and carbonic anhydrase inhibitors. And I've listed some of those there for you. You need to know, as I told you, meiosis and mydriasis. And meiosis is constriction, the other is dilation. And a lot of times they will put drops in your eyes before you get your eye test to cause your eyes to dilate. And then they can give it for infections in the eye, etc. You'll sometimes see older nurses like me using the terms OD, OS, OU, so right eye, left eye, both eyes. Though our textbook is telling us we're not supposed to do that anymore. And because it was through Joint Commission, it became a red flag of potential error, because you might not be able to tell that OU, which means both eyes, is not a D. So now we encourage you to write out the term right eye, left eye, both eyes. I need you to know what to do before and what to do after eye medication, and know how to instill eye drops. The big thing is once you put the eye drops in, we put a little pressure here so that the medication does not get in within the system. It stays in the eye. Okay? And that usually, when the drug we're talking about there are the beta blockers, so we don't want When the eye drop is a beta blocker, we don't want it to become systemic. And why is that? Because beta blockers, as you know, can slow the heart rate, slow down the systems, and you don't want to be causing a systemic problem with someone that you're wanting to just affect the eye. Also, you need to know that a prostaglandin agonist can actually change the color of the eye. And so patients may come to you and go, my eye is changing color. Well, you need to see if they're on one of those meds. And the beta blockers can cause worsening of asthma, and you've studied that before. So you need to know some of these side effects. I think if you study your quizzes, you should see, and your blueprint, you should be able to know that. Okay, moving along very rapidly. Chapter 31, drug therapy for male reproductive problems. You know, the prostate gland is dependent upon testosterone, and it's the main androgen secreted by the testes and adrenal glands. Androgens are a group of male sex hormones that includes testosterone, dihydrotestosterone, and androstenedione. Men over 50 can develop BPH, benign prostatic hyperplasia, and that's an enlargement of the prostate gland. It is benign, BPH. You'll have many, many patients who have BPH. The older they get, prostate just seems to enlarge. And men will say, I'm going to the bathroom more often, I get up at night, I can't seem to start urinating, I feel like my bladder is still full, and having dribbling, that sort of thing. So that is BPH. And we use DHT inhibitors and selective alpha-1 blockers. You need to monitor these drugs because they're metabolized in the liver and can be very dangerous. Testosterone is a hormone produced in the testes that help with development and maintenance of male sex characteristics. It helps with maintenance of muscle mass, adequate levels of RBCs, bone density, and reproduction. Testosterone is the replacement therapy used, and it can be taken orally. There can be patches, gels, pellets, and I've listed some of the medicines. This is a black box warning because women and children do not need to touch testosterone, and they don't need to come in contact with the linens, the old patch, any of that. Need to warn women about testosterone. Chapter 32, drug therapy for female reproductive issues. Estrogen is the female sex hormone, and it's secreted by the ovaries and the adrenal glands. And the secretion of GnRH stimulates the release of two hormones from the pituitary, the follicle stimulating hormone and luteinizing hormone. Progesterone supports, as we know, any pregnancy that occurs. It keeps the uterine wall thick and allows it to secrete nutrients for the embryo. You need to know what menopause is and perimenopause, and the hormone replacement drug for that is conjugated estrogens, Premarin, Prempro, and Premphase. Hormonal contraceptions, there's a combination drug, Yasmin, NuvaRing, Ortho-Evra, and the other ones there that you can read about. You're probably familiar with some of those. So rapidly, that is the last two chapters. I will ask you questions on your test about the last two chapters in the eye, but those should be covered in your quizzes and in your blueprint. I do want you to really understand diabetes and the thyroid gland, adrenal glands. So make sure you read that and understand that fully. Thank you.